about 5 lakh new cases of squamous cell cancer of head and neck worldwide per year, out of which about 40,000 in the United States. And despite continuous improvements in diagnosis, local management, and chemotherapy, there had been no significant increase in survival rates over the last 30 years. So actually what chemotherapy is, you all know, I think in the previous lectures also, chemotherapy in simple terms are use of drugs or novel agents which can kill tumor cells. And till now, chemotherapy primarily was used as a palliative measure. Until recently, it was typically administered during, before and after the radiotherapy or surgery. Let me put you one thing clear, that head and neck cancer primarily either it can be surgically excised or it can be killed at that point of time by the radiotherapy. But the use of chemotherapy, if it is done before radiation or before surgery, it is known as neoadjuvant. If it is used with radiation, it is known as concurrent. And if it is used after the use of surgery or radiation, is known as adjuvant. So, how to treat head and neck cancers? Usually in India, about 80% of patients present very late. In that case, it is just palliation. That means we are just going to decrease the tumor load, we are going to increase the longevity of patient and to increase the quality of life. But cure is out of purview. So surgery, cut it out, radiation, burn it, chemotherapy, selective poisoning, and either to combine all the modalities so as to get a good quality of life. Past, what happened? Classical chemotherapy is directed at metabolic sites essential for cell replication. So as we know, tumor cells replicate more frequently than normal cells. However, currently available chemotherapy does not specifically recognize neoplastic cells, especially it is in context with latest immunotherapies and latest modulatory drugs. And because chemotherapy is going to act on fast dividing cells, henceforth those normal cells in the body which are going to divide rapidly, especially bone marrow, GI mucosa, and hair cells are also affected. Hence, you will see many of patients who get chemotherapy usually have hair loss, may have ulcers, vomiting, and diarrhea because of GI mucosa. They will have a temporary bone marrow suppression because of the bone marrow suppression because of the chemotherapy drugs. So the most common drug which we used since 60s is methotrexate. It is structural analog of folic acid, binds to and inhibit DHFR reductase enzyme, which causes decreased intracellular folate coenzymes, which in turn is going to depress RNA and DNA synthesis and causing cell death. So this is mechanical of action. The drug number 1 is methotrexate. Second drug is 5-fluorouracil, 5-FU, very common drug. Like methotrexate, it deprives cells of essential precursors of DNA synthesis. Pyrimidine analogs, which has a stable fluorine atom in place of hydrogen at position 5 for uracil. You can see that in uracil, instead of NH group, we have positioned 5 is fluorine. So get it into the RNA and corrupt RNA. Henceforth, if there is no RNA, there is no protein synthesis. So this is the way mechanism of action of the 5-FU. So 5-FU got converted to fluorine deoxyuridine monophosphate, which competes with deoxyuridine monophosphate for thymidine synthesis, which leads to the lack of thymidine, imbalance in cell growth and cell death. So we all know that in RNA it is uridine and DNA it is thymidine, and thymidine is synthesized from uridine. So once there is any competitor or there is a defective thymidine synthesis, so DNA will not be replicated, henceforth there will be cell death. Third, the most important drugs is known as cisplatin. The full name is CDDP. Nobody will ask you full name, but you should remember cisplatin is known as CDDP. It was approved in 1978 by US FDA for the use in oncology, especially head and neck. It binds to guanine on DNA, forms inter and intra-strand crosslinks. Again, aim is to enable DNA synthesis, henceforth there will be cell death. Less toxic, easy to administer, another analog of cisplatin is carboplatin. It is less effective, but it has a low toxicity. Henceforth, we use in such patients in which we need cisplatin, but the condition of the patient is very frail or patient is not in good performance status, henceforth we use carboplatin instead of cisplatin. So it's not necessary to use one agent at a one time, so we can combine. So there were in 80s there were a lot of randomized controlled trials which compared availability of the chemotherapeutic drugs single versus combination. Cisplatin as a single agent was not superior to methotrexate. Similarly, multi-agent chemotherapy in general associated with high response rate than single agent, and the highest rate was those combinations in which we have one of the platinum analog, either cisplatin or carboplatin.